In this context, there hasn't been a lot of use of sunitinib in this setting, and there's been some pushback regarding the results because of some other studies that were contemporary studies that didn't meet their primary endpoints. Now, one of those studies, the ASSURE study, was a cooperative group study that looked at Sutent, it looked at sorafenib, and it looked at placebo, and demonstrated no difference in disease-free survival. But in that study, there were a lot of dose reductions all the way down to 25 milligrams of Sutent, and about 2/3 of the way through, they changed the dosing from 50 milligrams down to 37.5. That relative decrease in the dose intensity probably explains a lot of why we didn't see the efficacy. The reason I believe that is because when we look at a third study, the PROTECT study of pazopanib, a similar drug to sunitinib, it was also studied in the same kind of setting, and what it showed there, again, about halfway through the study, they changed the initial dose from 800 milligrams to 600 milligrams because of tolerance. But what we found was in the patients that started at 800 milligrams, there was indeed a statistically significant improvement in disease-free survival, similar to what was seen in STRAC, while in the patients that had the dose reduction from the beginning to 600 milligrams, we saw a reduction of that effect that was no longer statistically significant. So dose matters when it comes to adjuvant setting. The struggle is that dose also results in toxicity, and how to balance that is key. Identifying patients that have fully recovered with ECOG 0 following their surgery is important, and really counseling patients around the tolerance and being proactive with dose interruptions rather than dose reductions is really important. But if you do that, there's definitely a patient population out there that can benefit and tolerate this drug in the setting.